Welcome, everyone. My name is John Hart, and I'm here in Palm Springs at the USCAP Interactive Center. We're having a liver pathology course, which was under the direction of Dr. Rish Pai and includes Maria Westerhoff and Dr. Gindya as well. This session is on a bread and butter acute and chronic hepatitis cases, utilizing that pattern to develop a differential diagnosis and then arriving finally at a specific diagnosis that allows the clinician to manage the patient properly. So we have 18 cases to get through. I wish that you were all here who are listening to me from your offices and homes, but I would encourage you at some point to come out to Palm Springs. We're enjoying great weather and beautiful restaurants and a great hotel, so please check it out at some point. All right, so our first case is a 21-year-old male who presents with the nonspecific constitutional symptoms of anyone who has hepatitis, and that is fatigue, anorexia, abdominal pain. A lot of patients with acute hepatitis are completely asymptomatic, but if you have any symptoms at all, those are the kind of things that are common. And the liver chemistry tests show significant elevations of the AST and ALT levels, and the workup is completely negative. The serologic tests for A, B, and C, the autoimmune markers are negative, and he's not taking any medications, no alcohol, travel, diabetes, so forth. So it's kind of a common scenario to have elevated liver chemistry tests and a negative workup. Now they're depending on the pathologist to come up with the diagnosis. So whenever we're looking at a medical liver disease, I like to start by assigning a pattern. And I do that at low power. And this is a prototypic example of the acute hepatitis pattern. So what is acute hepatitis? It's all centered around the idea of lobular disarray. And lobular disarray is characterized by rather diffuse hepatocyte swelling or ballooning, many acidophil bodies scattered throughout the parenchyma, like you see here. Those are apoptotic hepatocytes. And then a rather brisk inflammatory cell infiltrate within the sinusoids. That's lobular disarray, and that is only seen in acute hepatitis as I'm defining it as a histologic pattern. Now, in every case of acute hepatitis, there is some portal inflammation, and in some cases, it can be rather brisk. But that doesn't mean that you should automatically jump to a diagnosis of chronic hepatitis. No cases of chronic hepatitis have lobular disarray, like I've defined it for you. So this lobular disarray trumps the presence of some portal inflammation and doesn't shift us to chronic hepatitis. And people who don't do a lot of liver pathology kind of fall into the trap of seeing a lot of portal inflammation and assigning it to chronic hepatitis, and I would encourage you to try to avoid that. Even if you have a so-called flare of chronic hepatitis, you never really get to this degree of lobular disarray. So lobular disarray defines this as an acute hepatitis, and once we've assigned that pattern, there is an extremely limited differential diagnosis, and that includes acute hepatitis A, B, C, and E. Some cases of autoimmune hepatitis can look a little like acute hepatitis, and then drugs and toxins. Now, A, B, C, and E, and even most cases of autoimmune can be defined by laboratory testing, and there's really no reason to even get a biopsy for those cases. So essentially, as a working pathologist, when you see this pattern, it's almost always a drug or toxin. A lot of patients with acute hepatitis E or A or C aren't even symptomatic, so they also pass through without having a biopsy. So just by recognizing this pattern reproducibly, we're pretty assured that this is a case of drug or toxin-induced liver injury. But you can see from the clinical history, the patient is not taking any medications, and we need to sign out our case. So how do we sign this case out? I would sign it out as mild acute hepatitis, and I would list drug and toxin as being the most likely etiologies. But if you just do that and sign out the case, as you're signing out the case, as you push the button on your computer, your phone will ring because the clinician wants to know a little bit more than that. First of all, they always are, is it autoimmune hepatitis? So you're going to need to make some comment. I don't think this case really has any histologic features that look like autoimmune. There aren't a lot of plasma cells here. The autoimmune markers were negative. It's a male patient, not a great scenario for autoimmune hepatitis, so I would feel comfortable saying in my comment there's no histologic features of autoimmune hepatitis. And then secondly, in a young patient, they may very well say, well, you didn't mention Wilson's disease. Could this be Wilson's disease? So could this be Wilson's? It can't be, because Wilson's disease causes steatosis in younger individuals and chronic hepatitis pattern in older individuals. It never causes acute hepatitis, so it's never going to look like this. And I think that really shows you the power of using a pattern-based approach for medical liver disease. If you can get the pattern right, your differential is extremely limited. And the differential for acute hepatitis, which, by the way, is all in the handout, all the differential diagnostic considerations are listed in the handout by all the patterns. Wilson's disease just doesn't appear in that pattern. So you can say in your report, there's no histologic features to suggest Wilson's disease, and feel pretty confident about that. So what is this case then? Well, it turned out when I reported it out, they went back to the patient. The patient said, oh yeah, I forgot to mention that I take a lot of ecstasy. So a lot of times patients don't regard things like that to be medications. And you can go to the livertox.gov website. I think you guys all know about that website. It's a very useful resource. You go in there, it's free. You type in either the generic name or you can just type in ecstasy, and then it populates out and it shows you that it causes acute hepatitis. And so then you have your final diagnosis. All right. Let's go to case number 2. Very similar kind of story, a young patient with the nonspecific constitutional symptoms of hepatitis, in this case abdominal pain, fatigue, nausea, vomiting, had taken a 4-week trip to India 3 months previously, and while she was there she had a flu-like illness and taken some herbal medication that she's not sure exactly what it was, but stopped that, came back to the United States, developed jaundice, and you can see that her AST and ALT levels are alarmingly high, 4,000 level. And the workup, A, B, and C, all negative. She does have a positive ANA, so we're going to have to consider autoimmune hepatitis. But the rest of the workup is all negative. So let's look at this biopsy, if I could find it. All right. So this fits very comfortably into that same pattern. It's just turned up to 11. So this is a rather severe acute hepatitis. It's showing the same lobular disarray. It's just that the ballooning now is really marked. The degree of lobular inflammation is really intense. There are more acidophil bodies. And yes, again, even though this is acute hepatitis pattern, you're always going to have some degree of portal inflammation, but you shouldn't go to chronic hepatitis for that. No case of chronic hepatitis would ever give you this degree of lobular disarray as I've defined it. And even in the so-called flare of chronic hepatitis, people in textbooks, you read about flare of chronic hepatitis. It's really just a little bit more interface activity, usually in those cases, not like this. All right, so did anyone have any thoughts about the etiology for this case? According to that, our pattern-based approach, it should be A, B, C, E, maybe autoimmune, and maybe drug. She was on that herbal, so I think that's a definite consideration. But you notice as you review the case that they hadn't tested for hepatitis E. And hepatitis E is endemic in India, where she had traveled, and so this is a nice case of acute hepatitis E infection. It doesn't, I'm not suggesting that you can tell this E case separate histologically from the drug-induced ecstasy case that we started with. There's no particular combination of histologic features that are going to separate it. So our job is just to come to acute hepatitis and give our differential and let them get to the final diagnosis. So in this case, if you were signing it out, you would say severe acute hepatitis, and then you would say, hepatitis E, given her travel history, hepatitis E is a definite diagnostic consideration. If that testing is negative, then a drug-induced liver injury would be the most common. Yeah? All right. Now, hepatitis E, in Chicago, we see it among our patients who travel to and from Mexico. It's endemic in Mexico too, so if you spend a lot of time down in Mexico, you can pick up hepatitis E, travel to India or Southeast Asia. But I'm starting to get one case a year of patients who just haven't traveled. And there are papers on that, and that's listed in your handout. Patients who are in group home settings, it's kind of similar to hepatitis A. It's transmitted in the same sort of way, contaminated water and so forth. So I am seeing it occasionally, and even today I don't think every clinician is savvy enough to order the hepatitis E serology. So it's something that I like to keep in my back pocket and break out in case of an emergency. So I'm always going to start with drug, because drug is the #1 for the acute hepatitis pattern. But if the hepatologist is being recalcitrant and says, no, John, I checked, he's the only U.S. citizen who's not taking multiple medications, then I say, well, of course, you've tested for hepatitis E, right? So that's kind of my back pocket emergency use diagnosis for the acute hepatitis pattern. All right, moving on to case well, let me show you one other thing. This is a common scenario too. So say it's a case very similar history to case #1, the ecstasy case. Mildly elevated liver chemistry tests, AST and ALT are 1 or 200, and the biopsy is done after a negative workup. And you get this biopsy. This is essentially normal. So what do you do in that situation where the biopsy is done for an elevated AST and ALT level, but it looks pretty normal? I think a lot of times people who don't do a lot of liver pathology would sign this out as maybe mild chronic hepatitis or mild portal inflammation, because you can always find a little bit of inflammation in the portal tracts. But when I have that history and it looks very normal, I try to look very carefully in the portal tracts for these pigment-laden macrophages that you see here, and these occasional Kupffer cells that have ingested pigmented debris here, cellular debris, and there's another one there. And that's really subtle, but if you get a PAS with diastase stain, it will highlight that. So now you can see it very clearly, the cellular debris from dead hepatocytes being cleared out, first out in the lobules by the Kupffer cells and then transported into the portal tracts, to the portal macrophages. So if I have that clinical history and I see this, I can sign this case out as a resolved episode of acute hepatitis. So in the US, you can't just get a liver biopsy the day that your liver chemistry tests are elevated. It takes some time to get that all set up. And in the meantime, the clinician usually says, stop whatever you're taking in case it is a drug-induced liver injury. So you may see it in this resolving phase, or in this case, I think you could even say resolved acute hepatitis. If there's a little bit more lobular inflammation and maybe 1 or 2 acidophil bodies, I'll sign it out as resolving. But this case seems good for resolved acute hepatitis. Not that uncommon of a scenario, so the PAS with diastase is very helpful in that situation. All right, case #3. 45-year-old female, 1-week history of right upper quadrant abdominal pain and malaise and jaundice, nonspecific kind of constitutional symptoms. No history of chronic liver disease. Now on physical exam, she's jaundiced. Her bilirubin is 3. Her AST and ALT are quite high, almost 1,000. And this time the testing shows that she does in fact have hepatitis C infection. She has a positive serum RNA level. But she also has a positive ANA, so that's going to buy her a biopsy to rule out autoimmune hepatitis, even though we essentially have here from this clinical information a diagnosis of hepatitis C infection. Also, in reality, this was the wife of a physician in our hospital, so that was also that overlay of they wanted to get to the diagnosis and be sure. So she got a biopsy when she probably honestly didn't need it. But it's a nice example of acute hepatitis C infection. So I hope as soon as I put this case down now, you can immediately say, oh, acute hepatitis pattern. It has all the features that we've talked about before, the slight ballooning, degeneration or swelling of the hepatocytes, the pretty brisk sinusoidal infiltrate of inflammatory cells, the scattered acidophil bodies, and there is going to be, of course, some degree of portal inflammation, but this degree of lobular disarray puts it squarely into the acute hepatitis pattern. So we saw drug-induced acute hepatitis that was kind of, mild. We saw very severe acute hepatitis E, and this is kind of a mild acute hepatitis C. Now, we hardly ever see these cases, and that's because almost all patients with acute hepatitis C are asymptomatic. And they never even can recall getting hepatitis C. They were never sick at the time, and it's only picked up with chronic elevations of their liver chemistry tests down the years later. So a nice case of acute hepatitis C. This one has a little bit of steatosis. It also has a little bit of bile duct irregularity. You didn't have enough time to preview these slides to really pick up on those features. But those features have been emphasized in the small case series of cases, this kind of reactive appearance to the bile ducts. Has been noted in series of acute hepatitis C cases, and as I said, there's not a lot. The best paper is, we published this case of acute hepatitis C because I thought it was so cool, but the same month, a better paper came out by Mike Torbenson from the Mayo Clinic describing 10 or 12 cases, but finding the same thing, a little bit of steatosis and this bile duct proliferation or injury pattern in addition to lobular disarray. Again, not suggesting that you can pick this one out as being due to hepatitis C versus the hepatitis E case or a drug-induced. We give the pattern, we give our differential, and then they need to fill in the blanks and come up with the final diagnosis. All right, let's move on to the next case. 65-year-old female presented in March 2009 with jaundice following a trip to Mexico for a wedding. And you can see that the AST and ALT are quite high again, and the hepatitis A IgM is elevated. Because the liver chemistry tests were slow to normalize and had been normal previously, so no history of chronic liver disease, they decided to just go ahead and get a biopsy. So this is a biopsy that's also pretty uncommon to be able to get to see a case of acute hepatitis A infection. But with that history, we were able to get this biopsy. And I included it in this because it's very typical of acute hepatitis A to look rather chronic. So I think putting this case down at low power, it's very easy to be fooled and think about the chronic hepatitis pattern. The portal tract infiltrates are the first thing that catch your eye in this case. And you have to hunt a little to see the lobular disarray, but it's there. It's just not as significant as the last three cases that we've looked at. So just a trap that we need to consider. Maybe some little clusters of Kupffer cells here in the background. But this is very nice for acute hepatitis A. It's kind of a mimic of chronic hepatitis. Interestingly, this patient had a history of bipolar disease. They felt like it was likely to be autoimmune hepatitis. because of the positive ANA titer at 1 to 80. And they actually, in spite of the fact that we signed it out as hepatitis A, acute hepatitis A, they offered her steroid treatment for autoimmune hepatitis. And she declined that because she was worried about her worsening of her bipolar disease while she would be on steroids. And she got better from her acute hepatitis A and avoided steroids. The reason I mention that is that we're doing a study right now with my current fellow, Dr. Rangia, and she collected all of our cases of acute hepatitis because we wanted to see whatever happened to those patients. Were we correct with our diagnosis? And what we found was that they sometimes ignore us. So it would say directly in the report, no histologic evidence of autoimmune hepatitis, but they would still treat the patient for autoimmune hepatitis because it's a young woman with an elevated autoimmune titer, and they just don't want to miss the opportunity to treat for autoimmune hepatitis. So I've always believed that one of my main roles as a liver pathologist is to stop a diagnosis of autoimmune hepatitis, but I've learned that even if I say no evidence of autoimmune, sometimes since that's the only thing they have to offer the patients get treated for autoimmune.
You see often with ANA positive in a lot of viruses?
All the time. That's a great question. The question was, these positive ANAs, to have a titer of 1 to 40 or 1 to 80, particularly in a female patient, is so common. And I'm sure you've all seen that in your NASH patients. It's one of the main reasons a NASH biopsy gets done. They know the patient has NASH. The patient has all the risk factors. They're obese. They have hypertriglyceridemia. They have diabetes. They're an obvious NASH case. But they also have a ANA of 1 to 80. So they'll ask you to rule out autoimmune hepatitis. And again, you need to be firm, no evidence of autoimmune hepatitis. And in NASH cases, I'm sure the previous lecture went over this, but as you accumulate fibrosis in NASH, you get more and more portal or septal inflammation. And so by the time you're getting up towards cirrhosis, it can be pretty brisk, but still resist unless you see a lot of plasma cells, a lot of interface activity, and the AST and the ALT are quite elevated. You don't want to say NASH with autoimmune overlap. Great question. All right. Let's move on to case number 5. 64-year-old male presented with dark urine and right upper quadrant pain, and the liver chemistry tests show very high AST and ALT, nearly 1,000. Nothing on imaging. Testing for A, B, C, and E, all negative. The ANA is negative. The anti-smooth muscle is negative. IgG is normal. So, and then they did this expanded infectious workup. Those are all negative and not on any medication. So essentially ruling out every last thing that could possibly cause hepatitis, and then they get the biopsy. So it causes a lot of stress for the pathologist, but we're going to take our pattern-based approach and assign a pattern at low power and go from there. So I hope that when I put this down that you guys are good with the acute hepatitis pattern. This has a little bit less of the swelling of hepatocytes. It's also just a thicker section and more darkly stained. But it does have everything else. It has lobular sinusoidal inflammation. It has acidophil bodies. You can see one there. It has the Kupffer cells laden with cellular debris, a little bit of dropout around the central vein as well. So this is an acute hepatitis pattern. So we have to stick to our guns on a case like this and say that this has to be a drug, since they've ruled out all of the other etiologies. So how am I going to sign this case out? I'm going to say this patient is an older male patient, so we're not thinking anything about Wilson's disease, and of course Wilson's disease doesn't cause acute hepatitis. Doesn't fit well for autoimmune, so I'm going to say mild acute hepatitis. In the comment, I'm going to say that there's no histologic evidence of autoimmune hepatitis, and I'm going to favor a drug or a toxin or an herbal supplement, something like that.
This one seemed to have some duct injury as well.
What's that?
I said this one looked like it had some duct injury as well.
Okay, excellent. So some duct injury is noted as well. And I think you're right. I think there is a little bit, maybe, I even consider duct loss in this case, but the keratin didn't show any duct loss. And the pattern of liver chemistry tests, when you see something like that, you want to go back and look. Alk Phos is slightly elevated, but not so much so that I still think it's a hepatitic pattern, because the AST and ALT are much higher than the Alk Phos. Yeah, that's a good point. So they went back to this patient, and it turned out he was taking green tea extract. Now, green tea has a lot of positive health benefits, but in the US, people take the pill form green tea extract, and that is a known toxic liver toxin. In fact, it's one of the more common ones that's been picked up by the NIH. And there's a recent paper, and I cited it in your handout, that says that if you have a particular HLA haplotype, you are specifically at risk for developing green tea extract, not green tea, but green tea extract related hepatotoxicity. So he had been taking that for several months, stopped it, and he got better. So, you know, there's all these herbal things that people take, supplements, dietary things that they might not consider as medications, but certainly are potential, at least, hepatotoxins. And let me show you this other case. Maybe we're not quite up to that. Yes, we are. So another kind of similar case, same kind of history. And just a little bit more severe. So again, no known etiology for this patient, and the viral workup was completely negative. But here, for this case of acute hepatitis, I'm starting to get a little bit worried. And here we're having a lot of periportal necrosis, which leads to this ductular reaction. And we're starting to get even a suggestion of bridging necrosis, not bridging fibrosis, because this is acute, but bridging necrosis, which is the connection of one portal tract to the next, or a central vein to a portal tract. And when you have that, that's a sign of severe acute hepatitis, and now we're starting to think about the need for a possible liver transplant. So here's a portal tract that's connecting to a central vein without any hepatocytes crossing any hepatocytes, and we're getting that ductular reaction in response to that. So this person turned out was taking red yeast rice, which is a well-known herbal medication in China and other parts of Asia, and is amazingly a very effective treatment. It has, I'm blanking on it now, the statin drug in it, lovastatin, is in that herbal preparation. The same chemical identical lovastatin is in red yeast rice, but the preparations of red yeast rice in the United States sometimes have very high levels of that compound, such that it's toxic. So this patient actually came in very confused, and we weren't able to get that history of ingestion of that medication, of that supplement. And within a few days, he developed severe hepatic encephalopathy, ultimately underwent a liver transplant. This is his native liver, showing the pretty dramatic loss of hepatocytes. There's only one stem cell population in the liver, or progenitor cell population, both for bile duct epithelial cells and hepatocytes. And for some reason, in overwhelming hepatic injury, the progenitor cells respond by proliferating ductules. So you get this marked ductular reaction. That doesn't help the patient in the short term. If the patient keeps their liver and survives this injury, these proliferating ductules will convert into hepatocytes and repopulate the liver. But this patient just simply didn't have enough hepatocytes left in his liver to sustain him for regeneration to occur. And in fact, if you look at the HepR, I just did for fun a HepR stain, he has little patches of parenchyma, but he has huge areas of his liver with essentially no remaining hepatocytes. So this is certainly needed a liver transplant. Went through that process, woke up, and then we got the history that he was taking this red yeast rice compound. So in a recent NIDDK study of herbal supplements causing hepatotoxicity, green tea extract and red yeast rice were among the most common causes of severe hepatic injury. And that reference is in your handout. Cool? Let's move on. The next case, case number 6, a 33-year-old female with type 2 diabetes, presents with severe abdominal pain, had a cholecystectomy 30 months ago for cholelithiasis, and the upper imaging shows the absent gallbladder, of course, and but otherwise completely normal. The liver chemistry tests show AST and ALT that are alarmingly high, 778 and 347, with just a mild, modest elevation of alk phos, almost normal. All right, so it seems like a definite case of acute hepatitis. And when I put this slide down, hopefully you'll say, no, this is not that pattern, all right? Nor is it the chronic hepatitis pattern. Instead, what we have are normal or nearly normal lobules. But instead, we have portal edema. See the loose quality here, that pallor of the connective tissue, and a little bit of ductular proliferation and ductular injury, similar kind of to that other case. Little attenuation of the native ducts and a little bit of ductular reaction. So I think this fits very nice into the biliary obstruction pattern of injury. Proliferating ductules don't have basement membrane the way the native ducts do. So when you have a lot of proliferating ductules, neutrophils come into the liver, into the portal tracts in response. So we're getting this neutrophilic reaction to this ductular proliferation. And that by itself shouldn't lead you to think of bacterial cholangitis. You don't suggest that until you actually see the neutrophils inside the lumen of the native ducts. When you have that, then you can diagnose bacterial cholangitis, ascending cholangitis. But this is certainly biliary obstruction. And I've included it in the acute and chronic hepatitis course or lecture because the AST and the ALT become quite elevated. So it's one of the causes of an elevated AST and ALT, and in particular, it seems to occur in patients who have had a cholecystectomy in the past. So they get a stone coming down and it lodges in their main duct. You have a lot of back pressure. You don't have a gallbladder there to absorb the pressure, so to speak. And it causes, for some reason, AST and ALT elevations. I think the bile acids reflux into the liver, injure the cytoplasm of the hepatocytes, and they become leaky, and you get elevated AST and ALT. So not everything with an AST and ALT elevation is acute hepatitis. And I think I mentioned that in the previous course on pediatric pathology for adults, the glycogenic hepatopathy, you remember that case, that was really high AST and ALT levels, not a single inflammatory cell. So those are two things that I always think about. Clinicians, in their mind, when they see AST and ALT, they're thinking acute and chronic hepatitis. But there's those two. There's also like alpha-1 antitrypsin deficiency. That's not acute or chronic hepatitis, but they have elevated AST. Same with genetic hemochromatosis. The AST and the ALT are mildly elevated, but there's no inflammation at all in the liver. So those are some of the things that we can think about in the differential. All right, moving on now to, I'll show you one other case that goes along with that, just for contrast. And this is a Psc case. So this is chronic biliary obstruction. That was acute biliary obstruction. That's why the alk phos was not that elevated. But here we have chronic biliary obstruction, and so we have fibrosis, duct proliferation, and bile plugs within the proliferating ducts. So this is chronic biliary obstruction, and here the alk phos you would expect to be significantly elevated. Okay. Moving on to case number 7. All right. So this is a 35-year-old middle school math teacher who presented with fatigue. That would be normal for a middle school math teacher to have fatigue. But he also has mildly elevated liver chemistry tests, and he's hepatitis C positive. Okay, so we kind of know the diagnosis. We're expecting to see chronic ACV hepatitis. But he also has a low platelet count, and he has spider angiomas and a palpable spleen. So what does those clinical features suggest?
Portal hypertension.
Right, portal hypertension. So he has cirrhosis, but he's only 35 years old, so that's a little peculiar. So we're going to look at this biopsy, expecting to see chronic hepatitis, and I'm kind of just using this case to contrast. Now we've entered into the phase of chronic hepatitis. So in chronic hepatitis, we have dense portal inflammation, and you guys all know what chronic hepatitis looks like. And the lobules are essentially normal, so such that if I was just to go to high power on any chronic hepatitis case and show you just this field, you would essentially accept this as normal liver. And that's typical of chronic hepatitis. Yes, I could go around and find a little lobular inflammation and a rare acidophil body in chronic hepatitis, of course. But it doesn't have lobular disarray. That's what I'm trying to illustrate. And now that we've hit the chronic hepatitis pattern, our differential is completely different. Now drug drops down to the very bottom. Extraordinarily rare to have drug causing chronic hepatitis. And B, C, and autoimmune move way up to the top. We always get biopsies for B, C, and autoimmune for chronic hepatitis because they want the grade and stage. It's not really for diagnosis, but for grading and staging. All right, so this patient has chronic hepatitis. We have to give it a grade and stage. You guys know how to do that. We assess the degree of interface activity and the degree of lobular necroinflammatory activity. I think this is a nice solid grade 2. Then we look at the trichrome stain and give it a stage. And I have that here. Or is it here? No, here. So we'll look at the trichrome stain. And he, in fact, does have cirrhosis of the liver. So it's a grade 2, stage 4 chronic HCV hepatitis, and that's how I would sign that case out. But it's unusual that the patient has cirrhosis due to hepatitis C at age 35. Hepatitis C is a very low-grade chronic infection. It's not like autoimmune hepatitis, where not uncommonly you get to cirrhosis by age 35. Here it's quite unusual, and so this is a thing where you have to think about some superimposed second injury. And I'll just show you the PAS with diastase stain to convince you that this patient has superimposed alpha-1 antitrypsin deficiency. So there's our globules in the periseptal hepatocytes, which is where we want them for alpha-1 antitrypsin deficiency. So you got to always be on your toes. It could be a second insult, and in this scenario, his young age with cirrhosis is the tip-off. If you guys get the PS with diastase on every case, you need to look at it then on every case. And it's really easy in a case like this where you already have your diagnosis to zoom through that to get to your endometrial biopsies and not see these alpha-1 antitrypsin globules. They're not easily seen on the H&E. So if you don't get a PAS with diastase on every case, you're going to really have to have a high index of suspicion to pick up something like this. Not that common, and we don't see Hep C cases anymore, so it's kind of historical interest, but I'm using it as an example of chronic hepatitis. And also, I do see it in patients with alcoholic liver disease and also NASH. you know, a patient who's 40 years old with NASH and they have cirrhosis, you need to think about alpha-1 antitrypsin being on top of that, or alcohol, or genetic hemochromatosis, that too. Second liver disease. All right, moving on to the next case. 12-year-old obese male, 1-week history of jaundice and abdominal pain. Patient's parents are from Mexico, and he travels to Mexico with them frequently. And because of the jaundice, they got labs, and you can see he has a pretty high bilirubin, but the AST and the ALT are also elevated. And they did the workup for hepatitis, which was all negative. But of note, he had started isoniazid for a positive skin test, or latent TB. His chest x-ray was negative. So latent TB, they put you on low-dose, long-term isoniazid, and here's the biopsy. And I'll just tell you that I'm trying to sell this as a case of drug-induced chronic hepatitis, but I've already given this in the other room, and they nailed me on it. They're like, that's not chronic hepatitis. There's some lobular disarray here. There is a little bit more brisk sinusoidal infiltrate here, and maybe a little bit of swelling. So it's kind of partially acute hepatitis and partially chronic. But I'll tell you, it's hard to find a chronic hepatitis due to a drug. So this is my case that I'm having to use for chronic hepatitis. But I think that's the lesson. You know, drug is way down at the bottom of your list for if you think it's chronic hepatitis, where it's absolutely at the top of the list. It's the first 10 things on the list for acute hepatitis. We're going to see some other kinds of chronic hepatitis that do occur with drugs. But to have just kind of a strict generic chronic hepatitis is kind of unusual. So in the handout, I go over the list of the drugs, the very short list of drugs that cause chronic hepatitis, and isoniazid is always listed as the number one. And it makes sense. It's going to be something that you're on chronically, right? If you're going to get chronic hepatitis, it can't be an antibiotic that you get for 10 days and then stop. So it's going to be chronic medications that are going to cause chronic hepatitis. But let me tell you, I haven't seen many in my career. All right. Moving along. And he had some fibrosis. I won't show you the trichome, but he did have some fibrosis. And the handout describes there are guidelines from the thoracic societies, the pulmonologists, on how to monitor any patient on low-dose isoniazid to make sure that you're on the lookout for hepatic toxicity, because it is a known cause. All right, case number 9, 45-year-old female, elevated liver chemistry test 5 years ago with a positive AMA and anti-ANA. And the biopsy, which I've never had the opportunity to review, apparently showed hepatitis grade 2, stage 2. She was not treated at that time. Now she's presenting with dry mouth and fatigue, and her labs show normal AST and ALT and a high alk phos. So let's look at this biopsy. And the reason I'm including this biopsy is to try to get you to believe without looking at that portal track. I always do that, and I know not to start with that portal track. This looks like chronic hepatitis with the exception of that portal track at low power. And that's how I look at liver biopsies with my fellow. She or he just says medical liver or liver mass or liver transplant. That's all I know to start. And I do try to start with the pattern, come up with a differential diagnosis, and then assign a specific diagnosis once I look at the labs. And, you know, if you look at a liver biopsy that way without hearing that history and look at this at low power, you could easily call this chronic hepatitis, and that's typical of PBC. So this is an obvious case of PBC. PBC occurs in middle-aged women. It presents between the ages of 45 and 55. They have a high alk phos, and they have a positive AMA. And she has all of that. So really, there's no need to even do a biopsy. It was only because of this hepatitis thing in the background that they were getting a biopsy to rule out superimposed autoimmune hepatitis. But autoimmune hepatitis is ruled out. We cannot diagnose overlap with autoimmune because the AST and the ALT are so low. You have to have a markedly elevated AST and ALT to do overlap. And that's really important in this case because you are going to find a lot of plasma cells in every case of PBC, sometimes big clusters. And they do spill over a bit, too, into the periportal parenchyma. So you don't want to diagnose autoimmune hepatitis in a PBC patient if at all possible because the steroids are the worst thing for these patients. Because of their PBC, their bones are very brittle. They're not absorbing vitamin D properly. They're older women, and if they, on top of that, you give them steroids, they have really terrible osteopenia. So it's really bad mistake to diagnose overlap. So don't let an impressive number of plasma cells and a little spillover into the parenchyma force you to go to autoimmune. You want to have the high AST and ALT and the positive ANA and brisk interface activity. PBC is really it's the same every time. You always have some portal tracts that are almost normal. And in the same biopsy, these portal tracts that are densely inflamed. That's very typical of PBC. And then it's lovely if you get the diagnostic. Isn't that the best?
Yes.
I mean, that's just glorious. Lymphocytic cholangitis with a little granuloma hanging off the edge. And this is as good as the granulomas ever get in PBC. That's the best one. Any better than that, then it's either an infection or sarcoidosis. Essentially, if the hepatologist sees the granuloma, it's not PBC. All right.
If the resident sees the grade.
Yes, right, exactly. Let me just show you, this patient had a huge biopsy, so it's in 2 cassettes. So let's look at this other core from the same patient. Now, can we diagnose PBC? It doesn't have that beautiful feature, right? Anywhere. So can we call this PBC? And I think the answer is yes. First of all, with an AMA that's positive in a middle-aged female with a high alk phos, it's PBC. So I'm going to really scrutinize this liver biopsy for any hint of any chronic biliary features. So maybe right here, there's an artery without a duct. And remember, in PBC, the ducts are damaged and then lost and vanish without a trace, as opposed to PSC, where they leave that fibrous knot behind, the fibro-obliterative lesion. In PBC, they just disappear, and they're gone. And then you get a little bit of collate stasis, the ballooning of the periseptal hepatocytes or periportal hepatocytes. So this case, I might order a CK7 to document this duct loss, focal duct loss. It might show a little bit of ductular proliferation. It may show biliary metaplasia of the periportal hepatocytes. I'm sure Dr. Pai showed you some examples of that. And I might even get a Rhodinene stain. If I saw 1 granule of copper, that would be enough too. But I'm comfortable signing this case without that other core as PBC and giving a grade instead. All right. The AMA is incredibly sensitive and specific for PBC as long as it's used right. If it's only ordered in a middle-aged female with a high alk phos, it's perfect. It'll be positive in all the PBC patients and negative in all the patients without PBC. It's only when some family practice person orders it in an acute hepatitis with high AST and ALT and a normal alk phos that you get the occasional false positive AMA. But used properly, and you have your internal control there. If the AMA is positive but the alk phos is normal, just ignore the AMA, right? All right, moving on to case 10. A 15-year-old, previously healthy female, has attention deficit hyperactivity disorder. I actually got to meet this patient. very short history. She was in a diving competition and did very well for her middle school or high school diving team. Performed well, then came down with these symptoms, actually ended up coming into the hospital for evaluation of her jaundice, and ultimately underwent a liver transplant just days later. So it all kind of went downhill very rapidly. You can see that her bilirubin level is quite elevated, even at time of admission to the hospital. AST and ALT are not high. Alk Phos is actually abnormally low, a big clue to the diagnosis. And she has some anemia. You can see that history gives away the diagnosis. Does anyone know the diagnosis? Also, she has cirrhosis of the liver. Wilson's, yes. Someone said Wilson's, yes. I'm sorry, I didn't. I was thinking about showing the trachoma. Yes, you're absolutely right, Wilson's. And that's one way of doing this case. You could do this case and just omit assigning a pattern and say, well, what causes cirrhosis in a 15-year-old? There's only like 9 diseases that cause cirrhosis at age 15. And you would be thinking mostly about Wilson's disease and autoimmune hepatitis. Those are the kind of the first two. Other things would be rare, like PFIC variants that we've talked about, or other metabolic diseases like tyrosinemia or glycogen storage disease that would be very obvious as soon as you put the slide down. But really, cirrhosis in a 15-year-old, that's a pretty limited differential diagnosis. And I can start with the trichrome to make sure that you're on board with me that this is cirrhosis of the liver. So she does have cirrhosis. So you're going to have a limited differential diagnosis. I'm trying to sell this as a chronic hepatitis pattern because the lobules are relatively normal and the portal tracts and fibrous septi have inflammation, but I'll admit it's not a very brisk chronic hepatitis. But if you have to put it into one, it fits into chronic hepatitis. So our chronic hepatitis pattern is B, C, and autoimmune. Way down at the bottom is drug. You're never going to have cirrhosis from a drug. So it's going to be a mimic of chronic hepatitis. And among the mimics of chronic hepatitis, the most important is Wilson's disease. So you get your Rhodinene stain. And I just want to mention that Rhodinene stain is a very easy stain to do. It's one reagent, and it works easily. It's not a finicky thing. So if you're getting a decent amount of liver material in your practice, you might want to consider adding the Rhodinene stain. It's not only for Wilson's disease, it's also really helpful in anytime you're struggling with a chronic cholestatic condition, because it will build up in the liver with chronic cholestatic conditions as well. Remember, you absorb every atom of copper that you eat gets through your intestine and into your bloodstream, and then you just excrete into the bile any excess copper that you don't need. But if you can't excrete into the bile because you have some biliary issue like PBC or Psc, then you're going to get copper accumulation in your liver. So it's not just for Wilson's disease. So here's the allograft, the native liver, from this patient. And now it looks a little bit more even like chronic hepatitis, and I'm going to go to the most chronic hepatitis-like area. So you could kind of accept that for chronic hepatitis and say there's a little interface activity here. And somewhere in here is a plasma cell. So if you're not thinking about Wilson's disease, you're going to kind of, and the clinicians will encourage you to say autoimmune. It'll be called autoimmune. If you treat the patient with steroids, they're not going to get better. So that's a clue that you've missed Wilson's disease. If they do have autoimmune, when you start the steroids, the liver chemistry test should normalize quickly. So the phone call you don't want is the young patient that you got browbeat into a diagnosis of autoimmune, and then they call you back and say this, or you get another biopsy, and they're like not responding to steroids. It's either Wilson's disease or it's drug-induced autoimmune, and they haven't stopped the drug trigger. That's what it always is. All right, and just to complete the Wilson's disease discussion, remember Wilson's disease falls in 2 categories. In older children and adults, it's chronic hepatitis, mimic. And in young children, it's steatosis. But never acute hepatitis, ever. So it's either steatosis or chronic hepatitis. And this was actually the sibling of a child who was diagnosed with Wilson's, so they biopsied the brother, and the brother had steatosis.
How bad does the steatosis get? Can it be really florid or?
Yep. So it can go all the way up to steatohepatitis.
Okay.
In fact, people have such low thresholds now for moving to steatohepatitis from just steatosis that most Wilson's kids are called steatohepatitis, not steatosis, because you can always find one balloon hepatocyte. And so, yeah. Yep, it could be quite a bit of steatosis.
And then, like,
too.
let's say a 30-year-old would be more of a chronic hepatitis?
Yeah,
then?
now
Okay, all
you've
right.
completely left steatosis. It's amazing. It's really, it works.
Okay.
The Wilson's disease cases in a 30-year-old or a 40-year-old will not look like acute hepatitis or NASH or any other pattern. They only look, you have to ram it into a pattern, it's going to be chronic hepatitis, like the one I showed you. And you're going to get considerable pressure to call it ANA negative autoimmune hepatitis.
Okay.
Or, if it's a woman, they could have a titer of 1 to 40, and you have nothing else. They've ruled out B, C, autoimmune is what's left over. And so you're going to say chronic hepatitis grade 1, stage 3, and in the comments say, although the ANA titer is negative, this could be autoimmune hepatitis. And then they don't respond to steroids. It's a hard diagnosis, Wilson's disease. It's always a difficult case. All right, case number 11. Young patient, 7-year-old, 3-week history of diarrhea, nausea, and vomiting. Monospot was equivocal. CT, of course they do, is negative. And the liver chemistry tests show mild elevations of the AST and the ALT, but the entire workup, which was extensive, is completely negative. Everything's negative. All right, so we have mild AST and ALT elevations in a kid. So we look at this biopsy, and I think this fits really nicely into chronic hepatitis, right? Kind of on the young side, so probably not Wilson's. That would be more like steatosis. What's the exact year cutoff where it transitions from steatosis to chronic hepatitis? Probably older than 7. So I'm not thinking about Wilson's here, but I don't have anything else either. It doesn't look like autoimmune because it's not brisk enough. So you're going to have to sign this case out as mild portal inflammation or mild portal and lobular inflammation, because there is a little bit of lobular inflammation too. So how do you handle these cases? Anyone have any ideas on what could be the etiology here?
Well, it could be biliary, like Psc.
Yeah, biliary tract disease can cause portal inflammation if it's chronic. If she's passing stones, say she was like a sickle cell patient and she was forming bilirubin stones and she had that crud. If you're passing that intermittently, you can get a little portal inflammation. We see that a lot in patients who donor livers in the middle of the night when you stamping your feet, going in to do that donor liver biopsy. They've ruled out all the infectious causes, of course, otherwise they wouldn't be a potential donor. But you often see a little portal inflammation. I think it's often because of a little chronic intermittent biliary tract disease. So that's definitely a consideration here. This particular case, the patient had this history of diarrhea, nausea and vomiting, and my most favorite liver disease is celiac disease. So this patient had celiac disease. So any kind of chronic intestinal inflammation can cause a little bit of portal inflammation. Now in the celiac patients, it may be more than that. It may be slightly an immune response, because when you put the patient on a gluten-free diet, they tend to get better. Of course, their intestines are getting better too. So I'm not exactly sure, but any kind of chronic intestinal inflammation will give you portal tract inflammation. So every patient with chronic diverticulitis, if they ended up becoming a donor liver and you did a biopsy, you would see a little bit of portal inflammation, or an autopsy, you know, if you did an autopsy. Any patient with IBD, Crohn's or UC, they're going to have a little bit of portal inflammation present. So, celiac disease, if you diagnose celiac disease on a liver biopsy, you're famous in your hospital. You get to strut through the halls, and you get a free wrong diagnosis with that same hepatologist anytime in the future. You could say, okay, yes, I blew this case, but remember that time I diagnosed celiac disease on a liver biopsy. So, yep.
Does microscopic colitis cause the same?
Oh, that's a really good one. I think it does. Yeah, I think the patients with collagenous colitis and lymphocytic colitis often have a little bit of portal inflammation too. Yeah. Great question. All right, case number 12. 34-year-old female, history of hypertension. And, you know, celiac disease, there's a lot of untreated celiac disease out there, so it will happen, and you'll be a hero. All right, 34-year-old, history of hypertension, abdominal pain, AST and ALT are quite elevated. The ANA is markedly elevated. The anti-smooth muscle is also elevated, and the patient has hypergammaglobulinemia. And she's female, so we have everything we need. This had better be autoimmune hepatitis, and it is. So this is kind of what I expect autoimmune hepatitis to be when it's treated. Once untreated, once it's treated, then it could be a difficult diagnosis to make because a lot of the plasma cells and interface activity go away. But when it looks like this, there's nothing else that is in the differential. We have marked interface activity, grade 3 activity, big clusters of plasma cells, everything we need for the diagnosis in this case. So an obvious autoimmune hepatitis, and we just need to assign a grade and stage. What happened to my other papers? Here they are. And so we use the grading and staging system. I like the Ken Batts system for grading and staging of autoimmune hepatitis, the same that we used in years past for hepatitis C and that we use for hepatitis B as well. So we're going to expect this patient to completely get better when the steroids are instituted in short order. The AST and the ALT should normalize. But this was a case of drug trigger autoimmune hepatitis, and it was due to methyl dopa that she was taking for that hypertension history. Not an agent that's used very often anymore, methyl dopa, because it causes autoimmune hepatitis. But treating with steroids alone is not going to be satisfactory for a patient like this. So you need to think about drug triggers. And the reason I included this case is because it had quite a few EOs, which you didn't have time to look for. But it does have quite a few EOs. But that said, autoimmune hepatitis has a lot of EOs. I used to think that the EOs were kind of a subtle clue for it being drug triggered, but there's been a couple convincing papers now that's saying that you have a lot of EOs in de novo autoimmune hepatitis. So just need to keep in mind the possibility of a drug trigger, particularly if there's not an adequate response to steroids. And the drugs that are commonly caused are the ones that you're on chronically, like antihypertensive, methyl dopa, also nitrofurantone for chronic recurrent urinary tract infection in women, and minocycline, which is a treatment in teenagers for acne. So a young girl with acne who's been on minocycline for a year or two suddenly develops autoimmune hepatitis. They really do have autoimmune hepatitis, but you need to treat with both steroids and stopping that drug. All right, moving on to case number 13. So this is a 38-year-old with a history of ulcerative colitis who also developed a thymoma, and that was treated with resection and chemoradiation therapy. Now new onset nausea and very high AST and ALT levels. Negative for the complete workup except for the ANA titer is quite elevated. And this is another case of autoimmune hepatitis. This biopsy was actually done after they started the steroids for a few days, so it's not quite as florid as some of the other cases of autoimmune hepatitis, and the plasma cells are not quite as prominent. But the reason I'm gave this case to you is for this giant cell transformation. Isn't it beautiful?
It is.
It's just really nice giant cell transformation of hepatocytes. Something that you see regularly in infants who are undergoing biopsy with neonatal cholestasis due to anything, but is really uncommon in adults. And it means nothing, unfortunately. So it's really fun to see, means absolutely nothing. So the patients who have this and autoimmune hepatitis act exactly the same as the patients with autoimmune hepatitis who don't have giant cell transformation of hepatocytes. So it's just kind of a cool finding. Doesn't mean anything. But I thought I'd throw it in there. So this patient was treated for autoimmune hepatitis, continued treatment, and did well. And honestly, I have my best cases of autoimmune hepatitis with giant cell transformation have been in patients with thymoma. So I think that the thymoma has something to do with at least a subset of those cases. The other scenario where you get autoimmune hepatitis and giant cell transformation of hepatocytes in adults is in CLL. And I don't know why that is, but here's my other beautiful case of giant cell transformation of hepatocytes in autoimmune hepatitis. But it's hard to diagnose the autoimmune hepatitis because there's also CLL here in the liver. So, but there's the giant cell transformation. There was a paper years ago saying that parvomyxovirus infection was responsible for adult giant cell transformation of hepatocyte, but that was published in the New England Journal of Medicine. Never replicated by anyone, so I think that idea has just dropped out. All right, moving on to case number 14, very important case these days. The patient who has widely metastatic solid tumor, in this case melanoma, and is being treated with checkpoint inhibitors. Life-saving medication, but you've all seen the GI toxicity that occurs. It can look like IBD, it can look like, it has upper tract GI, can kind of look like autoimmune gastritis, really severe GI mucosal injury. Dead ringer for autoimmune, or for IBD in the colon biopsies, but often with a lot of apoptosis. And unfortunately, it also has very severe liver toxicity. So here is the liver toxicity to the clinicians. This is autoimmune hepatitis. That's how they think of it. Checkpoint inhibitor causes autoimmune hepatitis, and they treat it like autoimmune hepatitis with steroids. They don't care what you call it. To them, it's autoimmune hepatitis, and they'll even add Imuran as well in some cases. Histologically, it's not perfect for autoimmune hepatitis. It's a brisk hepatitis, kind of acute and chronic features, sometimes some central lobular dropout, like you see here. Plasma cells are usually not very prominent, but there's often, like in this case, lots of acidophil bodies and lobular inflammation. There's an acidophil body there. So there's a great paper by Dr. Mizraji on this topic of checkpoint inhibitor toxicity. It's referenced in your handout. I think it was in Modern Path this year, or last year now. And he makes the very important point that these patients they have widely metastatic solid tumors. So they've recently stopped conventional chemotherapy with really high doses. They're often on TPN. They're on multiple antibiotics, antifungals, antivirals, and they're on multiple checkpoint inhibitors, often used in combination. So it's not surprising that you're going to find a multitude of different histologic appearances with checkpoint inhibitor toxicity. This is, I think, the most common. It just kind of looks like a generic chronic hepatitis of some type. And that's what I see most often. But let me show you another case of a patient on combination checkpoint inhibitor toxicity. This patient has steatosis, which I really don't think is due to the checkpoint inhibitors, has some poorly formed granulomas, but also a lot of lobular and portal inflammation. So to me, this is also checkpoint inhibitor toxicity. And this is discussed in Dr. Mizraji's paper. And here's another patient where they stopped the checkpoint inhibitor toxicity agents, and so the toxicity is resolving. But my very sharp-eyed fellow at the time found the ovarian serous carcinoma in the lymphatics, in the liver, in one portal tract. So
Nice pickup.
just, yeah, there's always something, right? And then this was the most recent case I had from December 17th. The patient was on checkpoint inhibitors for a widely disseminated vulvar melanoma, had got checkpoint inhibitor-induced severe hepatitis, so they had to reduce the doses, stop it entirely, treat it with steroids, Imuran, still having liver toxicity. So they gave her a rest period, but she had widely disseminated vulvar melanoma. And so they started a new agent, which they often try, because it was being effective. And then she redeveloped severe liver injury, high AST and ALT. So they got a biopsy to rule out checkpoint inhibitor toxicity. And this was the melanoma in the liver, all through the liver and the sinusoids. So a lot of things to consider in these patients on checkpoint inhibitors. All right, moving on to case number 15. 53-year-old obese female with Hashimoto's thyroiditis and arthritis, and has been treated on and off with steroids. Stopped them, and then her liver chemistry tests were starting to go up, and she was starting to develop fatigue and malaise and a weight gain. ANA, of course, is positive because she has Hashimoto's thyroiditis. ANA is anti-smooth muscle is also slightly elevated, 1 to 20, and she's on several medications, and so they got a biopsy. So let's look at this very interesting biopsy. I really like this case. So we'll look at it the way we're supposed to, starting at low power. And at low power, it kind of looks like the lobules are normal, and there's portal inflammation. So I'm starting off with calling this the chronic hepatitis pattern, right? Yep. But then when you look at it actually at medium or higher power, the inflammation is around the central veins. So this is a central vein with inflammation. Here's another central vein with inflammation. And this portal tract is completely normal. There's the bile duct. So the central veins have inflammation, acidophil bodies, and clusters of plasma cells, like you see there and here. Same thing around this central vein, plasma cells. So the more you look at this biopsy, the more it looks like stone cold normal portal tracts with exquisite central vein, plasma cell predominant infiltrates. What do you guys think? Yeah, autoimmune. So it's just the central lobular variant of autoimmune hepatitis. Great paper again by Dr. Mizraji on this topic. It seems like it could be an earlier form of autoimmune hepatitis, or it could be that these patients have a specific HLA subtype of autoimmune hepatitis that's central lobular in nature. And some of the patients go on to develop regular portal-based autoimmune hepatitis as well. But it's an uncommon pattern, but it's important because these patients need steroids at the same dose as the regular patients. There's no grading, though. How can you grade this? We can't use the same grading system, so I just sign it out as autoimmune hepatitis central lobular variant. And then, of course, you're going to get a phone call. You can throw on Dr. Mizraji's paper as a reference to your report, and they treat with steroids.
Sometimes they'll see that after they've been treated.
What's that?
So sometimes they'll see that after they've been treated.
Yes,
with
and after,
steroids.
that's a good point. And yeah, the more you look at your regular autoimmune hepatitis cases, the more you see that central lobular as part of it, you know. And then you're right, as you treat, sometimes the central lobular stuff hangs around more and the portal tract stuff disappears a little bit. Yeah. Yep, that's a good point. All right. Case 16. 4-year-old with fever, rash, and lymphadenopathy. Doesn't sound like a liver case. Laboratory testing revealed, good, an elevated bilirubin and a very high AST and ALT. Peripheral blood eosinophilia also noted. Workup is negative. Patient had been started on phenytoin and phenobarbital for new onset seizures.
These are some old drugs.
Yeah, those are hepatotoxic drugs, right? And this is a really bad liver, very severe. And it fits into the autoimmune category, but this is a particular variant called DRESS syndrome. So drug eruption, and it's all in the handout, peripheral blood eosinophilia and hepatitis. And this is a medical emergency. These patients need to get off that drug right away because steroids alone will not reduce this at all, and they'll go into liver failure and need a liver transplant if they don't stop the drug. The drugs are pretty much the anticonvulsants. Mostly it's all the anticonvulsants like this patient's on. So that combination of peripheral blood eosinophilia plus a skin rash and then hepatitis, that's very alarming. And honestly, I haven't had that many cases. I've had a few over the years. The clinicians, the hepatologists are not always thinking in that direction, so you can really save someone's life. Histologically, the EOs are prominent, but acceptable for just kind of regular autoimmune hepatitis, but this would be really bad autoimmune hepatitis just on its own. Just wanted you to see a case of DRESS syndrome. Yeah. All right. Case number 17. 19-year-old with fever, chills, rigor, and nausea and vomiting. Doesn't sound like a liver case either. Admitted when the fevers increased and fatigue developed. And his bilirubin is slightly elevated. His AST and ALT also slightly elevated, as is his alk phos. And the workup is completely negative, but the CT shows hepatosplenomegaly. And they repeat the liver chemistry tests, and they're going up slightly, so that's going to buy you a biopsy. So let's take a look at this case. More of a systemic illness than others that we've had. And I'm including this case to try to convince you that this is a separate category. This is not acute hepatitis, because although we have a lot of inflammatory infiltrating the lobules, it's all in the sinusoids. And the hepatocytes are completely healthy here. No ballooning, no acidophil bodies, no damage at all. It's just a sinusoidal infiltrate. It's not chronic hepatitis, even though there are dense portal infiltrates, because no chronic hepatitis has this sinusoidal infiltrate like this. So it's its own pattern, separate. And we could call this sinusoidal hepatitis or lobular hepatitis, right? And so what's the differential for that? You guys have any?
EBV.
Yeah.
And
EBV.
also lymphoma.
Yeah. So yes, exactly. EBV, drug, And the one drug is dilantin, and then you definitely want to consider a lymphoproliferative disorder of some sort. So might want to run this by your heme path colleagues, look at the peripheral blood smear, that sort of thing. But this was EBV hepatitis, which goes along with the fever history. Now, if we do an EBER in this case, we'll be lucky if we have one positive lymphocyte. And remember, it's not in the hepatocytes, it's in the lymphocytes. Immunocompetent patients have very few EBER positive cells, so it's whatever's circulating in their blood gets into their liver, and that's all we're going to see. It's not like a post-transplant patient where you do the EBER and you have many positive lymphocytes. So even if the EBER is negative, this can still qualify as EBV hepatitis in an immuno. And I can't show it to you, unfortunately, because it's faded over the years. This is an older case, but it was positive. Let me show you one other case, very similar, essentially identical. Portal inflammation, sinusoidal infiltrate. I mean, really pristinely normal hepatocytes. But this is dilantin hepatotoxicity. For some reason, it just can look identical. So if you can identify this pattern and keep it separate from acute hepatitis and from chronic hepatitis, your differential is EBV, lymphoproliferative disease, and dilantin. All right, last case. 54-year-old female with colitis and a persistently elevated serum alkaline phosphatase level, alk-phos 216. And so they did kind of, 54-year-old woman, you're definitely thinking about PBC. But the AMA is negative. So then you think about, well, what about AMA negative PBC? That requires the ANA or the anti-smooth muscle to be positive, and they're both negative. So that rules out both a PBC and AMA negative PBC. And so they just followed her, continued to be elevated. They interrogated her biliary tree by imaging. It's normal. Repeat the liver chemistry test, still elevated. Going to have to get a biopsy. All right. So we look at this biopsy, and there's not much here. It's kind of desperation time as soon as you put it down. You know how sometimes you put down the case immediately, and you're like, uh-oh, this is going to be a problem.
Yeah, that's when it goes to the side.
Yes, put it to the side, get out that tray of GI biopsies, so satisfying. Get that done, cast around a little bit for other cases, and then you come back to this one. Yeah. So it's hard to even assign a pattern. There's a little bit of portal inflammation, there's a little bit of lobular inflammation, and you probably didn't have time to find it, but there's a couple granulomas. Yeah, you saw that? Yeah, right here?
Yeah.
All right. So the easiest way to deal with this is just to say granulomatous hepatitis, because then the differential is 100 pages long. I actually don't like this for granulomatous hepatitis. I don't think there's enough hepatitis to call it. I try to separate my granuloma cases from my granulomatous hepatitis cases. This is kind of on the border. Maybe I would go with granulomatous hepatitis. Granulomas by themselves, just granulomas without much inflammation, are usually, sometimes they're sarcoid, but they're usually just idiopathic. You never figure it out. Or a foreign body, you could polarize. Granulomatous hepatitis is usually drug or infection. If the patient has systemic manifestations of infections, fevers, weight loss, night sweats, immunocompromised patient, it's probably infectious. If they don't have any of that, it's probably drug. So that's kind of how I deal with this. This is kind of minimal for everything. So what are we going to go with here? I tried to go out with the intestinal inflammation idea. Maybe this patient has diverticular disease, celiac disease, something along those lines. Then you find out when you have the fellow go look in the electronic medical record that this is a CVID patient. And this is kind of classic for CVID. Common variable immunodeficiency, they have non-specific mild portal and lobular inflammation, sometimes with a granuloma or two. And I think it kind of fits, for me, as I think about it, into the chronic intestinal inflammation category. Because those CVID patients always have a little bit of ongoing intestinal damage, increased IELs, kind of look like celiac sometimes, kind of look like lymphocytic colitis sometimes. So I think this case, and there's a good paper that I list in the handout, I think by maybe the Hopkins group, talking about these nonspecific features, and that little granulomas are very common, and that the ALK phos is usually the predominant elevation of the liver chemistry test. Now, because the patient has CVID, they're going to make you stain the granuloma because, right, they're at risk for infections. Always negative, 100% of the time. But just go ahead and order an AFB and a GMS. It'll always be negative. All right. Thank you. I know that's a lot of cases, but this is kind of bread and butter. We'll see all of these things. Thank you very much for hanging in there. I guess now we're going to have, when they're done, we're going to move to the audit. Did anyone?